While you may not notice them and others can make you faint, every time you stand up, you can give yourself a head rush or even pass out. These delirious episodes are caused by a rapid drop in blood pressure having stood up, otherwise known as orthostatic or postural hypertension. This hypotension will almost always occur unless you change position very gradually, though only some reach the point where they will cause a head rush. Hypotension is commonly confused with its antonym, hypertension, meaning an abnormally high blood pressure, though both refer to changes in the body's normal blood pressure of around 120/80 mm of mercury. This number may seem slightly strange, as you may expect the average blood pressure to be a single number, though it has to do with the cardiac cycle of the heart. The human heartbeat consists of two distinct phases. Firstly, there is the contraction phase known as systole, in which blood is pumped out of the heart. Then, there is the relaxation phase known as diastole, during which the heart relaxes and fills with blood. The nature of these phases can be measured using an ECG, which is a medical device that measures the electrical pulse of the heart. Since the heart undergoes a series of electrical changes relating to waves of excitation, sensors that are connected to a monitor can detect these electrical signals. A typical healthy ECG trace shows what is known as the PQRST shape. Wave P is the stage that corresponds to atrial systole, referring to the excitation and contraction of the atria. Then, ventricular systole forms a QRS complex, and the start of ventricular diastole corresponds to the T wave. It is these two phases where we get the two blood pressure measurements, systolic and diastolic. The systolic pressure, or the first number, is the maximum pressure during systole, and the diastolic pressure, or the second number, is the minimum pressure during diastole. These are measured in millimeters of mercury above atmospheric pressure. Three main factors usually affect blood pressure, and when someone has hyper or hypotension, it can usually be attributed to abnormalities within one or more of these three factors. The first of them is cardiac output, which refers to the volume of blood pumped by the left and right ventricles around the body. It is measured in liters per minute and can be calculated by multiplying together the person's heart rate and stroke volume, which is the volume of blood pumped out of the ventricles per beat. Factors which affect heart rate include autonomic innervation, hormones, fitness levels, and age, and stroke volume depends on heart size, fitness levels, gender, contractility, duration, preload or muscle stretching before ventricular filling, and afterload, otherwise known as resistance. For a healthy 70 kg person, the average cardiac output would be around 5 liters per minute, and sound cardiac output is crucial for adequate tissue perfusion, which is an organ supply of fluid from the circulatory and lymphatic systems. Cardiac output is also related to oxygen delivery, or DO2, which is equal to the cardiac output multiplied by the arterial oxygen content, or CaO2. Standard oxygen delivery for a 5 litre per minute cardiac output is around 997.5 milliliters per minute. Another useful measurement is VO2, which is the percentage of circulated oxygen consumed through metabolism and is approximately 25% at rest. There are multiple ways cardiac output can be measured, one of which is Doppler ultrasound, in which a probe sends out a sound wave of a particular frequency, which returns at a different frequency due to the velocity of the blood, which can be calculated to determine cardiac output. Other commonly used detection methods are pulse pressure methods, impedance cardiography, ultrasound dilution, electrical cardiometry, MRI, and dye dilution methods. The second factor which affects blood pressure is the systemic vascular resistance, which is the resistance beyond which the heart can generate flow through the circulatory system. The final factor to consider is the arterial stiffness, which increases with age and is attributed to an increased risk of hypertension, heart attack, and stroke. Now we've explained the precise meaning behind the word hypotension, let's explore what orthostatic hypotension is. Orthostatic hypertension is defined as a systolic blood pressure drop of at least 20 mm of mercury, or a diastolic blood pressure drop of at least 10 mm of mercury within 2 to 5 minutes of standing. This is because 10 to 15% of blood pools in the legs when standing up, and this decrease in blood pressure can be aided by dehydration, which reduces the overall blood volume around the body. There are 3 types of orthostatic hypertension, which depend on how quickly this pressure drop occurs. If the drop is sudden, then it is described as vasovagal. If it occurs within 3 minutes, it is described as classic, and if the reduction is gradual, then this is delayed orthostatic hypotension. When we stand up, the autonomic nervous system is activated, and 3 things usually increase to combat gravity and maintain regular blood pressure. This includes the heart rate and myocardial contractility, which is the ability of the cardiac muscle to contract with varying degrees of force, which usually depends on the degrees of binding between myosin, thick, and actin, or thin filaments. Systemic arterial vasoconstriction and venous vasodilation also increases, redirecting blood away from the vessels in the legs and back to the heart. Then, there is the skeletal muscle pump, in which the skeletal muscles involved in standing contract to aid the return of venous blood to the heart. The respiratory pump works as the pressure in the thoracic cavity is decreased during inspiration, thus reducing right atrial pressure and increasing venous return. These all work by increasing venous return, which is the return of blood to the heart. If these mechanisms fail and the blood pressure drops previously mentioned occur, less blood is returned to the heart, resulting in reduced cardiac output and blood flow to the brain, known as ischemia. During ischemia, the brain is temporarily deprived of adequate oxygen supply, causing symptoms such as dizziness, fainting, vertigo, and temporary blurriness of vision. Although the majority of people experience head rushes only when standing up quickly, other causes may include alpha blocker and vasodilation medications, autonomic neuropathy, or hypovolemia, which is a severe condition that results in decreased blood volume. During hypovolemic shock, a person loses more than 1/5 of their body's fluid or blood supply, which is life-threatening. Head rushes almost always resolve themselves on their own. Just know that next time you rush out of your chair too quickly, you may find yourself right back at square one, flat on the floor.